Great. So thank you all for coming. Welcome to today's DaRe2THINK webinar series. So we've been running this now for a couple of years, and it's great to see all of you come and join us. Do spread the word to any of your teams. It's obviously not just restricted to DaRe2THINK. We're very happy to share knowledge across all of primary care. And we've had some amazing speakers, as I'm sure you'll realise. Abby will probably put in the chat some of our previous meetings over the last year at least, when you can have a look at those on YouTube. Fantastic today. We've got an amazing speaker, Kim Rajappan. So Kim's a consultant at the Oxford University Hospitals at John Radcliffe. I've known Kim for many, many years, and he was one of the country leads for a really pivotal trial that we ran for the European Society of Cardiology called STEER-AF, where we showed that actually getting people to target on their treatment can actually have massive implications for patients and also improve their long-term outcomes. So really great to see Kim. Kim's an electrophysiologist, and he's going to talk to us today about patients with palpitations and how can you optimize their care in primary care. So thank you so much, Kim, for joining us today. Please tell us what you can about this area, and I'm sure you're happy then to take questions and comments at the end. Thank you very much.
Thank you very much, Deepak. I'll share my slides, and thank you very much to you and the team for inviting me to speak today. Let me get my slides up and running. Bear with me for just a moment. Thanks. Okay, so yeah, very kind to have that introduction. Deepak actually too modest to say that he was the chief investigator for that study, a really pivotal study looking at education. Given we're here, education is what we're all about, aren't we? So forgive me, the title of this talk, I thought I'd put it this way because actually palpitations, one of the most common presentations in primary care. I'm told by all my friends who work in primary care, and whilst I sit in a secondary care or tertiary care position, I try to sort of envisage what it's like to deal with this in primary care, where really the vast majority of patients with palpitations present and are dealt with. I'm just going to get my laser pointer working. If you give me just a second. Great, there we go. So pretty common type of scenario for those of you who work in primary care. I know there's a variety of healthcare professionals and indeed various people who are involved in healthcare on this call, but specifically our primary care physicians and nurse practitioners, etc. You'll be familiar with this 25-year-old lady who comes in, has a history of palpitations, often for many years actually, but they've increased in frequency, and she's understandably concerned because people are concerned about an awareness of abnormal rhythm in their heart. She's otherwise, though, completely well, often on no regular medication. It's how do we approach this young lady? Because actually, when we look at the rhythm abnormalities in patients and in individuals in the population, I should say, actually, rhythm abnormalities are relatively uncommon. A lot of these palpitation symptoms will just be awareness of normal rhythm variation, but there are a group of people who have atrial fibrillation, and as we get older, that becomes more common. Likewise, atrial flutter. Ventricular tachycardia remains a very, very low number across the board. Of course, that's the one we're probably concerned about, but actually it is low, so we don't need to be really too concerned. I'll come back to that. And there's a few other types of what we call supraventricular tachycardia, or SVT here, AVNRT and AVRT, that sort of peak around the sort of 20s, late 20s, 30s, 40s, and then drop off again. All these numbers are quite low, actually. In the vast majority, it's actually this. It's an awareness of what we refer to as ectopy. These are premature beats that occur from either the atrial or the ventricles, ubiquitous in the population, although some people get more than others, and some are aware of them and some aren't. People can become aware of them. And indeed, just faster normal heart rates, what we refer to as sinus tachycardia. That's by far and away the large proportion of these patients who present with palpitations. But how do we distinguish between these ones that have what one might consider a more benign problem, albeit disturbing in terms of the symptoms, but still benign, versus something else? It's really the history that gives us the clue. So most diagnoses of patients with palpitations, I believe, personally, can be made from the history alone. Ectopy has a very classical history. The person presents and they say, yep, I've been aware of this often for years, as we said, although sometimes they become aware of it at a point in their lives. Hard to explain because they will have been having this all their lives, but for whatever reason they become aware. They very commonly describe them as being brief. They'll sometimes describe them as a fluttering sensation. But importantly, they can also very much describe them as a skipped beat, because what happens is a person has a normal beat, they then have this premature beat, which is the ectopic, but they don't feel that. And then the next normal beat kicks in a little bit later than one might expect, and they feel it as a skip. Importantly, they can be little short runs of these, or indeed even longer runs. So they'll say, yes, it starts fluttering, it's skipping, and it goes on for even minutes or hours, sometimes on and off and on and off. But that doesn't necessarily mean it's anything more sinister. That classical history of the brief flutters, skip beats, even if it goes on and off for long periods of time, can still represent this relatively benign phenomenon in many people. Some people will identify precipitants. Worth asking about things like alcohol, caffeine, etc. Stress is definitely in there. Exercise, rarely. Normally exercise helps actually with these. But it is a fluctuating phenomenon. That's important to point out. People may say that they'll go periods of time where they're far less troubled by them. They suddenly flare up, sometimes with a precipitant, sometimes without an obvious one, and then they settle again. That is just normal rhythm variation. Importantly, for the clinicians who are wondering, could this individual have atrial fibrillation? For example, if they're an older individual and you do not want to miss atrial fibrillation, because we know there are very important treatment aspects that need to be considered in someone who has atrial fibrillation, not least anticoagulation. These can cause an irregular pulse, just clinically taken. So don't assume it's AF. Frequent ventricular, frequent ectopy, I should say, either atrial or ventricular, can certainly cause an irregular pulse that would very much mimic atrial fibrillation just done clinically. So, yeah, it is important to just keep that in mind. As I've said already, more sustained symptoms, even ones that go on for hours, days even, can sometimes still represent this relatively benign phenomenon. And so just keep that in mind as well, please. What about more sustained fast heart rates or tachycardias? What do we do about those? These are patients who clearly describe them increasingly. People with their wearable technology are coming in and saying, oh yes, my watch is, or my Fitbit is telling me that I'm getting episodes of 140 beats a minute when I'm doing virtually nothing. And that may or may not be symptomatically disturbing, but clearly psychologically disturbing, if nothing else. Well, we can take some aspects of the history again to give us some clues. If it's very sudden onset and offset, that makes some of those SVT mechanisms that I mentioned, AVNRT or AVRT, more likely. These are mechanisms where people are actually effectively born with extra electrical connections in their heart, often very benign, but can cause palpitations and symptoms. If it's a more slow onset and a slow offset, and they'll say, yes, it gradually comes on and gradually goes off, then think about other things like sinus tachycardia, which is a more normal heart rhythm, but just behaving a little bit abnormally and coming on a bit fast when it shouldn't do, but it gradually goes faster and gradually slows down. Or indeed some of the other types of tachycardia like atrial tachycardia, atrial fibrillation, although there'll be other aspects of the history that might give you a clue there. For example, with the atrial fibrillation, they might describe an irregularity of the palpitations as well as the fast heart rates. I don't think duration helps an awful lot here. They can last for minutes, they can last for hours. Days of SVTs like AVNRT or AVRT are very rare, but more sustained ones, yes, could really be any of these. What is quite helpful is if the patient can actually do a Valsalva type maneuver and stop them from occurring. So if someone says, yeah, I can pretty reliably, I've found that if I squat, hold my breath, they'll stop. That definitely makes some of the SVTs more likely. Unusual for patients to be able to terminate things like atrial fibrillation, for example, with that sort of maneuver. So again, history really is key. I can often make a pretty good determination on what I think this person will have by looking just at them as an individual and also from their history of the palpitations. Past medical history, though, is important, particularly if we're think about red flags, because actually, as I said, for most of these, it's going to be benign, but if someone has an extensive cardiac history, they have heart failure, ischemic heart disease, that might be more worrying. Not necessarily, could still be benign, particularly if the story sounds like benign ectopy or some sort of inappropriate sinus tachycardia. But just be aware that if someone does have obvious structural heart disease, particularly a history of it, perhaps be a little bit more alert to the possibility of something a bit more serious in terms of arrhythmia. Loss of consciousness, whilst often raised as a red flag in the setting of palpitations, in my opinion, is not always a red flag. And again, we come back to the patient who has structural heart disease, clearly some abnormality, whether it's a past medical history or indeed when you examine them or do the ECG, we'll come to those in a moment, you find there's something clearly abnormal there. That definitely does create a degree of concern. But in someone who has a normal examination, normal ECG, actually a structurally normal heart almost certainly on that basis, those patients don't lose consciousness with palpitations because of the palpitations. It's normally something else, often benign, quite commonly something like vasovagal syndrome. Often an overlap here. Exercise-induced palpitations are often referred to as being a red flag, but I've said the same again. I don't think that's always the case. Clearly, nothing ever is always the case, but actually not as often. And you've got to, again, put it in the context of the individual, just as I've said with the episodes of loss of consciousness. Someone who's otherwise really very well, not too worried about that at all, even if it's exercise-induced, probably still benign, where someone who has structural heart disease, I would be more concerned. These conditions have become quite tricky, I think, for many people to manage as healthcare professionals, what we call inappropriate sinus tachycardia, and a description of a phenomenon where people stand up and their heart rates inappropriately go very fast, we call POTS, or postural orthostatic tachycardia syndrome. I actually think these are very common in the population. Indeed, probably to some extent, many, if not all of us to some extent, might experience these at some point, particularly around viral illnesses. Our heart rates do some funny things. The key here is that we need to identify these patients. History, we'll come back to some of the other things we do as well. Reassure them and not over medicalize these. The history could sound like SVT, absolutely, but often there are other, what I've described as autonomic symptoms. Those are symptoms related to what we call the autonomic nervous system. These control temperature regulation, they can affect bowels, they can affect concentration. There's a variety of different symptoms that may come in association with the awareness of effectively tachycardia or fast heart rates. But I have put here, and forgive me, I don't mean to be in any way presumptive, but this can be diagnosed in primary care. I understand difficult to manage, but it can be diagnosed. So if we're just thinking about diagnosis, well, I've said we should do an examination for these patients. We've taken a history, probably got a good idea already of what's going on, but we do need to check. Have they got signs of structural heart disease on examination? It's very rare in my experience to pick up systemic disease like thyrotoxicosis without them having obvious florid signs of being overactive with their thyroid. But as we've also said, if it is precipitated by things like exercise or posture, well, then we can try and reproduce that. The active stand test is a really nice test that I know does take about 15 to 20 minutes in total. But if it can be organized in primary care, you take the person into the room, you lie them flat. I don't think it has to be a full 10 minutes. 5 minutes is normally enough. Record the baseline heart rate and blood pressure, then you stand the individual up. That's all you have to do. And then again, record heart rate and blood pressure without them leaning against anything for up to a 10-minute period. And you're recording that at the start of standing, 2 minutes, 5 minutes, and then 10 minutes, and documenting any symptoms that occurred during that process. Because if the heart rate goes up very dramatically, defined as being an increase of greater than or equal to 30 beats per minute in that 10-minute period for an adult or 40 for children, then that suggests this individual probably does have what is described as POTS. Just a description of what is occurring. It is not really a diagnosis per se. It's just telling us what happens with their heart rate. Everyone's heart rate's increased a little bit, by the way, when we stand up. It's just not normally so dramatically. And importantly, this has to occur without a significant drop in blood pressure, because if there's a drop in blood pressure, a bit like we see down here, then actually that's more an orthostatic hypotension. And there can be overlap in these two. The important thing is that these, whilst often debilitating in terms of symptoms, are benign, generally benign conditions, and just need to be managed as carefully and cautiously as possible without too much medicalization. But I do appreciate that can be a challenge. What about other investigations? Well, I think all patients who have palpitations should have a 12-lead ECG, even the ones, dare I say, who I think give a very benign history. And I appreciate I am speaking from my sort of ivory tower in my university teaching hospital, but I would hope that, not with any urgency, it would still be possible to provide a 12-lead ECG in primary care over a period of time. Often that resting ECG, assuming they're not having symptoms at the time, will be completely normal, and that's reassuring. Normal examination on cardiovascular examination, normal ECG means essentially almost certainly a structurally normal heart, almost certainly. You might capture the palpitation symptoms on the 12 ECG, of course. That would be great if that happens. It doesn't happen very often, but if it does, and they happen to have some ectopics and they say, yeah, those are my symptoms, that's perfect. Or indeed the tachycardia, very, very occasionally. But you might also see some of these things that I've mentioned. So evidence of a previous MI, may or may not have known about that, evidence of some conduction tissue disturbance that makes you alert to the fact that there might be something more going on here. Things like pre-excitation on the ECG, I'll show you one of those, QT interval prolongation, or indeed this very, not very common syndrome called Brugada syndrome, but just a few things you might pick up from the rest of the ECG, not common. This is an example of pre-excitation. So if a person has palpitations and has this appearance, we call these the delta waves. So if you're looking at lead V1 here, here's the P wave. There's almost no gap between the P wave and the QRS complex, and this very short PR interval with the so-called delta wave, this upward slurring rather than a flat line and then into the QRS is very classical of pre-excitation, an extra electrical connection in the heart, and in the setting of someone with palpitations described as Wolff-Parkinson-White syndrome. What other investigations? Blood tests are often done, and certainly when patients are referred to us, we often get some blood tests sent to us, often normal. And we're back to the fact that most of these individuals' palpitations are benign in the first instance. And secondly, actually, if they are otherwise well, have no significant pathway history, normal cardiovascular examination, and indeed possibly normal ECG, then actually their blood tests, including thyroid function tests, are normally going to be normal. But I think one of the key things here when we're managing these individuals is capturing the rhythm at the time of symptoms. And I put this in, and I forgive, I've highlighted this bit in yellow because I think this is really important. I think a lot of so-called routine cardiac monitoring is suggested from secondary care. Our primary care colleagues phone in or send in advice or ask for advice, and we sort of say, oh yeah, do a monitor. And actually that comes inappropriately, because if someone is not going to have symptoms during that cardiac monitoring period, and indeed everything else has suggested it's benign and they've got a normal examination, normal ECG, that is not going to help you move forward with that individual. It's really quite a waste of both the patient's time and your own resources. So if they are having daily symptoms, absolutely put on a 24 to 48 hour Holter monitor, and you may well be able to capture the rhythm at the time of symptoms. If their symptoms are once or twice a week, more prolonged monitoring is definitely possible. There are now patch monitors available that can even be up to a couple of weeks. But actually, if you're starting to get symptoms that are less frequent than once a week, and certainly less than once a month or so, you're starting to run into difficulties with any of these external monitors. Some people will have personal monitors. The Cardia device is one that a number of our patients might purchase for themselves. And indeed, some institutions now even provide to patients Apple Watches, of course, and other types of watches. I shouldn't just advertise Apple, but there are other devices. These devices might become useful in those individuals where the episodes are relatively infrequent but last long enough that they might be able to capture them on those. But please don't routinely organize a 24-hour Holter monitor for the single episode palpitations in someone, or ones where they say my palpitations occur once every month or two, because that is just not going to be helpful. But I apologize that you do get that advice from a variety of sources, including some that I would argue are probably meant to be relatively educated, like cardiology departments, but that is not the right advice. I've got an algorithmic approach to these patients. I'm not going to actually go through all of this slide, not least because of time. This is going to be recorded, so people will be able to look at this, but there are a variety of symptoms that might lead you to think that one particular symptom is more likely to be caused by a potential rhythm variation. I'll leave that in my chat that's there, and the recording that's there for people to look at. And likewise, this algorithmic approach here that I put in, which is one that we use, I'll just sort of highlight what I think is important in my last minute or so, which is there are clearly individuals that we can group as low risk in primary or secondary care, any setting really. The short-lived infrequent symptoms, lack of red flags, normal examination, normal ECG, we have to try and just reassure them. Yes, possibly if you want to do something more, you can think about investigating, but actually we should be trying to reassure them based solely on our initial clinical assessment. There's this group here that have very intrusive symptoms where we have to probably do a bit more, even though we're not worried that they particularly have red flags, but it's interfering with their quality of life. And here we may have to do a little bit more to try and help assess them and decide whether there's more that we need to do. And it's really only these individuals over here who have red flags, severe structural heart disease, a very abnormal ECG, a very abnormal history, family history, inherited kidney disease. They're the ones who I think would benefit from referral on to secondary care, tertiary care, and getting further investigation and advice. A relatively small group, I hope you'd all agree, of the vast majority of patients that we see with palpitations. So to summarize, I think the history is all important in patients with palpitations presenting at any present healthcare sort of scenario, but particularly in primary care. A brief cardiovascular examination is actually an amazing thing that can so reassure us if it's normal. And if you can do something like an active stand test, then that's really helpful in making a diagnosis. I think a 12 ECG is really helpful and ideally done at the same time or before the assessment, so you've got it there to hand and you can give that reassurance straight away. Please consider cardiac monitoring only in selected patients where you know that the monitoring is going to be helpful, whether that's organised in primary care, through secondary care, or indeed personal monitors. It can be helpful, but it can also be totally unhelpful and a bit of a waste of time. And as I've said, there are a relatively small group of people who absolutely, please do refer them to secondary care. They may well benefit, but actually the vast majority of these patients are going to benefit from your expert input. For those of you who work in primary care, they're going to be reassured, they're going to be on their way with actually no need to ever come near secondary care. Thank you very much indeed.
Fantastic. Thank you, Kim. I think I probably speak for everyone here and say you can come back. That was really helpful because it was really practical. And I think I'm sure the primary care colleagues will really appreciate that you've taken the time to think about things from their aspects. We do have a couple of minutes for questions. You can either sort of put your hand up or put things in the Q&A or the chat, and we'll have a look at that. Just while everyone's thinking, I guess, just a quick question. I mean, what are your thoughts on where you think it is kind of benign and doesn't need to then go on about using maybe a small dose of beta blocker propranolol or something to see if symptoms disappear? Do you think that's a reasonable thing to do in primary care? Absolutely,
but yeah, and forgive me, time didn't allow me to go into the actual, yeah, you're right, the complexity of management once you've made the diagnosis, because that's, yeah, of course, you're right. I've said, yeah, make the diagnosis, but management difficult. Yep, small dose of beta blocker for symptomatic purposes. I always emphasize for symptomatic purposes, no problem with that at all, actually. If they feel better for it, absolutely great. If I can reassure them though sufficiently, that's even better. Actually, we know that some of these patients with inappropriate sized tachycardia and POTS are the very hardest to actually get to feel well. But again, I hope what I was trying to get across there was once that diagnosis is made in primary care, actually just reassurance, it will get better, fluid, salt, all the other measures that we've done, and just taking away the concern that could be something really sinister wrong with their heart hopefully helps a lot. But yes, great suggestion. Small dose beta blocker in a lot of people with even benign, what we would consider benign palpitations. If it helps them, why not?
That's great. Oops, sorry. That's great. Thanks. So question from Pete from Newport Pagnell. Which Valsalva might you recommend for a healthy young person with no comorbidities?
Yeah, Pete, actually, most people who've come to us, I find, have already worked out the Valsalva. They found out how they might do it themselves. The one that I recommend where I think they've got an SVT that might respond to a Valsalva, I say you could try this and see whether it helps, because that might almost be a diagnostic process, because if it does, that points towards certain types of SVT. I actually just go for the lie down, ideally lie down, certainly sit down, lie down, ideally elevate legs, because that returns more blood flow to the heart, which seems to help with the Valsalva. And then I mean, you won't be carrying a syringe, most people aren't, so I normally just say pinch nose, close mouth, and blow out as hard as you can for 3 seconds, and then breathe suddenly. That's generally the easiest way to do it. There are a variety of things, but that's the one I go for.
That's really helpful. Yeah, I think if you happen to be in the GP surgery or whatever, then if you've got a 20 ml syringe, I find that's quite an easy, quick way of doing it. You don't have to get them lie down, but that's helpful.
Yeah.
And then just very briefly, just Lauren mentioned the Apple Watch. Is this something that's reliable history in terms of patient history, and has it been approved for use in these arrhythmias?
Yeah, a great point, Lauren. I mean, yes, the physician needs to interpret. I often say to my patients, if they bring me these strips, look, don't necessarily believe the interpretation you see. There's quite a lot of data on this, and to keep it down to a few seconds. Some of them are very reliable with what they tell you. Some of them give a diagnosis that is not very reliable, and that's just the technology. Cardia is approved actually for diagnosis of AF and CE mark, so that is one of the devices that you could say pretty reliable. Although, by the way, even that, when it says possible AF, is not by any stretch of imagination highly reliable, probably 70% or so in my experience. So ultimately, you have to have a look at those traces, or indeed we do. So we get quite a lot of primary care people sending traces into us for us to look at, then come back to them.
Yeah, and just to mention, and this is picked up in the guidelines we wrote for Europe, got published last year and the year before, but remember there's two different types of devices: those that provide an ECG, which is I think what you're talking about, Kim. Of course, the vast majority of commercially available wearables just use a light sensor, and that is not the same. And so obviously there's a big distinction there. They can both be used in certain ways, but in terms of diagnosis, I think we have to make sure that they are, as you said, ECG relevant devices. Great. I mean, we could spend all day with you, and I'm sure you'll get some more questions as we come through. By all means, have a look at the chat, and if you have time to reply to a few. If we don't get to everything, then we can always get Kim to email you back with the advice. I just want to hand over to Minnie very briefly, just to end today's session on DaRe2THINK. But again, thank you all so much, and thank you, Kim, for that incredible masterclass on palpitations. Minnie, do you want to present a few slides on DaRe2THINK just to end the session today? Thanks.
Yeah, Abby, please. The second slide. Next to that. Okay, so the DaRe2THINK trial is a randomized controlled trial to prevent stroke, premature death, and cognitive decline on patients with AF using their healthcare data for pragmatic research. So the trial is sponsored by University of Birmingham, funded by NIHR, and we work in collaboration with Clinical Practice Research Data Link. So the project is looking at using routinely collected primary care data to integrate clinical research to usual care. That reduces the burden on both NHS staff and patients. So the DaRe2THINK trial is an exemplar of this new delivery method and targets key public health issue of how to prevent cognitive decline and dementia in patients with AF. So the trial can screen weekly over 13 million NHS records to identify potentially eligible patients. And so far, there are more than 500 GP practices who are actively engaged in screening and recruiting patients. And we have recruited so far more than 1,300 patients to the trial, and they have been randomized. So to randomize one patient, at least we need 5 patients to be recruited for the trial, and 1 patient is randomized every 5 patients enrolled. And we're continuing to recruit patients, and the uptake is 20%, which is one out of 5 patients. So slide 2, please. So we're continually improving the database platform, and the current database platform is now much better. It could enable to recruit patients quickly and randomize patient. And now, for those practices who are currently involved in the trial, and if you have any question and you want to book a meeting, kindly click the left QR code. And for those new practices who are interested to take part in the DaRe2THINK trial, click the right QR code to book a meeting. So third slide, please. So we are conducting this webinar every month. So just wait for the announcement of the next webinar in the coming months. And if you have any feedback for this webinar, kindly click the QR code. Thank you very much.
Great, thank you, Winnie. Thank you, everyone. Great to see you. Have a good summer. We probably won't have one, by the way, in August, just because everyone's away. But we'll pick up with the schedule next year. But have a great summer if you're away, and hope to see you all later in the year. Take care. Bye.